I'm Mark Schuster, and I'm going to be talking about our new measure, Child HCAHPS. And first, I'm going to give a little bit of the context of how we came to develop it through the Pediatric Quality Measures Program. Then I'll talk about the development process, our national field test, and then what's coming next. So the Pediatric Quality Measures Program was established in 2011. It was actually part of the CHIPR legislation of 2009. And the Agency for Healthcare Research and Quality and the Centers for Medicare and Medicaid Services, CMS, co-sponsored it. And the mission is to develop pediatric quality measures that will be in the public domain that everybody can use. And they're meant to be available to public and private purchasers, payers, providers, and consumers. And to do this, they established 7 centers of excellence. And we are one of them, the Center of Excellence for Pediatric Quality Measurement. And one of our assignments, they assigned us what measures to develop, is Child HCAHPS. And just to get us all on the same page and remind us, although I realize I'm speaking to the most knowledgeable people in the world about patient experience, but patient experience measures cover aspects of care that patients value, that we know that patients want to learn about. There are aspects that patients can directly observe, so we don't ask them how well the anesthesiologist performed during surgery. And there are aspects for which patients are generally the best source of information. So we're also not asking whether the antibiotic that was prescribed was the right one. In our case, of course, it's family experience of care, but the same principles apply. So I want to take us through the development process, just a brief overview. So we started off with our formative work. We did our literature review, reviewed existing measures. We interviewed as many experts in the field as we could find. A Federal Register notice was released by AHRQ that invited anybody to send in suggested topics, items, surveys, anything they wanted us to look at. We were delighted that Press Ganey sent in its survey, which was really great. And then we took all that, put together a protocol, and did our focus groups. We did them in 3 cities around the country in English and Spanish. They were mostly with adults, but we did do some with adolescents. The survey is for caregivers, but we wanted to still get that adolescent voice into our process. We took all of that formative work, and then we put together our draft survey. And then we put it through what I think was the most important part of the process. We did 94 full cognitive interviews and 25 partial ones. That's where we did one-on-one interviewing. People would take the survey in front of us, and we would ask them questions as they went. What did you think that meant? What did you mean by your answer? And that's where we found that things that we thought made perfect sense didn't. We had one item where we asked where you went after you left the hospital, where your child went. Did they go home to another healthcare facility? And some people were checking off healthcare facility who we knew went home. They'd stopped at the pharmacy on the way home to pick up their prescription. So it's where you learn that your language isn't always as clear as you think. So after that and those were in English and Spanish in 4 cities around the country. And then we had our draft, fixed it after the cognitive interviews. We did our pilot test. That was in 8 hospitals around the country. We had 2,000 surveys, and that was super useful for seeing what items were just being skipped that weren't supposed to be skipped, whether there were 2 items that really correlated highly that were getting very similar results so that we could cut one of them, whether there were some items where everybody's at the top so that there's just no room to move, and whether there is variation across institutions and how people are responding. So we took all that, worked on the survey some more, and then did our national field test. And I'm going to talk in a little bit more depth about that in a moment. But I also wanted to include our end-user cognitive testing, which is often left out of the process in general in survey development, but was very, very helpful. We took it to parents and showed them results packaged the way we thought it might be packaged, and learned a lot about how to package our findings in a way that would be useful. So it helped us come up with labels. You know, our items are a whole bunch of words with a question mark at the end of them, but we had to come up with labels. And then we have, and I'll get into this, 18 measures in the end. And that's a lot for people to process. So what we found, by grouping them in 5 categories, it made it much easier for parents to absorb the information. So I want to plug end-user cognitive testing. Should also say, all this work was done by a very large team. I'm the one who gets to present it today. Sarah Toomey, who Jim mentioned earlier, we were partners in doing this, and she would have been here but had to go present at another meeting. But there were a lot of people in town in Boston and also around the country. We had a national stakeholder panel and a lot of partners in this, including the original CAHPS consortium partnered with us too. So our national field test, it was in 69 hospitals, as Jim said, in 34 states, over 17,000 surveys. Press Ganey was one of our partners. Many of you were our partners in this process. It was by mail or telephone, and a little over a third were freestanding children's hospitals. 4 out of 10 were hospitals within a hospital, and the rest were general hospitals. And here is the final survey that came out of all of this work. It's 62 items. We have 39 patient experience items. We have 11 screeners so that we ask if the child got any medications before we ask the item, were you told about potential side effects of medication so that people can skip items that aren't appropriate for them. We also have demographic and descriptive items, and then we have the open-ended item, which is free text, where people can tell us anything that's on their mind. Those 39 items that are the experience items, the meat of the survey, then become 18 measures. Some of them are single item measures, some are composites. And as a reminder, a composite is where we put together more than one item that conceptually goes together so that it can be reported together so you're not looking at 39 results. And I mentioned the end user testing and the categorization. We have the 5 overarching groups: communication with parent, communication with child, and interestingly, parents wanted them kept separate. They viewed that as separate, and they wanted to understand both. That's the kind of thing we learned from all of our testing. Attention to safety and comfort, hospital environment, and global rating. So we have 3 main types of response options. And I'm going to just give us examples of each, and in the process, give an example of some of the items. So first, we have a 4-point scale. Always, usually, sometimes, never. An example is, during this hospital stay, how often did providers keep you informed about what was being done for your child? And then we have a 3-point scale. A child's regular activities can include things like eating, bathing, going to school, or playing sports. Before your child left the hospital, did a provider explain in a way that was easy to understand when your child could return to his or her regular activities? Yes, definitely. Yes, somewhat. No. And I should say we've previously defined in the survey what a provider means. And then the hospital rating item, using any number from 0 to 10, where 0 is the worst hospital possible and 10 is the best hospital possible. What number would you use to rate this hospital during your child's stay? And here, you all are familiar with this. This kind of material is reported as a top box score. So always, yes, definitely, and 9 and 10 for the hospital rating item. So I'm going to take us through our 18 measures. So the first grouping, as I said, is communication with parent. And keeping you informed about your child's care gets 72%. And the top box here is the average of the 69 hospitals, their top box scores. And that first measure is a composite. So just to go over what composites are again, in this case, it's a 2-item composite. The first item is the one that I read to you before about keeping you informed. And then the next one has the screener, what I said before we have 11 of. Tests in the hospital can include things like blood tests and x-rays. During this hospital stay, did your child have any tests? And if the parent answers yes, then they answer, how often did providers give you as much information as you wanted about the results of these tests? And you can see it's the 72% is an average of 68 and 76. The composite's very simple. It's just an average of the items in it. So to go back to this, we have communication between you and your child's nurses and your child's doctors, communication about medicines, privacy, keeping you informed in the ER, and preparing for discharge. And the range of top box scores is 72 to 84%. Our next grouping is communication with child, and how well nurses, how well doctors communicate with your child, and involving teens in their care. There are 3 items that we ask only of parents with teens. Attention to safety and comfort, preventing mistakes and helping you report concerns, pain, responsiveness, helping your child feel comfortable, And these are our lowest scores in general, ranging from 56 to 74%. Cleanliness and quietness, also some room to move there. And global rating, the overall rating is 75%. That's the item that goes from 0 to 10, and would you recommend the hospital? 82%. This is that global rating item, and I wanted to show you, it's the 69 hospitals are along the x-axis. This is each hospital has a bar, and this is the percent, this is the top box score, the average top box score for each hospital. And you can see again the average, that red dotted line, is 75%. And what you can see is there's wide variation above and below the mean. And there are 19 hospitals that do significantly better than average and 11 that do significantly lower than average, which is showing us that there is variation, but also all hospitals have room to move. There's, we can all learn from each other and how to do better. Now, this one incorporates all 18 of our measures. So again, there are 69 hospitals along the x-axis. The y-axis is our 18 measures, a count of how many of our measures a hospital is above the mean, which is green, at the mean, which is blue, and below the mean, which is red. And let me take you through this a little more slowly. This hospital, you can see, has 3 of its measures, of its 18 measures, at the mean in blue, and 15 below the mean in red. This hospital has 2 above the mean in green, 9 at the mean in blue, and then the bottom, it has 7 in red, 7 below the mean. And then this hospital has 16 above the mean and 2 at the mean. And clearly some hospitals generally do better than others. You would, be more excited about this hospital than the one on the far end. But they all, no hospital is always above the mean. No hospital is always below the mean. So again, there's work to be done at all of our institutions. We can all learn from what one hospital, many hospitals have above and below. There's room to move, and that's why this kind of meeting is so great, because we're all brought together to learn from each other. So what's coming next? We are released. We are on the AHRQ website. We are available for download. All the support materials are there. As Jim mentioned, we've gone through the National Quality Forum process. The technical panel voted it up unanimously, and it's going through all the other layers of approval there. So that process is done. NQF also runs the Measures Application Partnership called the MAP, which is actually a separate process for them. But what it does is it advises CMS, the Centers for Medicare and Medicaid Services, on what measures should be put into the national core set, which is the set that CMS recommends states report on. And so it reviewed a whole bunch of measures and prioritized them and picked out 3 as the high priority measures that it felt were most important to be added into the core set. CMS is advised by that committee, not controlled by it. So now CMS is deciding what to do and has said that they are going to set up a pilot process to determine what's the best way and the feasibility of having the information reported by the hospitals to the states and then the states up to CMS. So that is expected to unfold over this year. Just want to thank you all for embracing Child HCAHPS, for Press Ganey, being a partner with us all throughout, and for making it available now and having us here. So thank you.